Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise, and welcome to the show. If you're watching us live, great, glad to have you on board. Hey, I just received this little comment from YouTube. Your hard work is paid off. Your channel got 301% more views than usual. So, hey, that's thanks to you guys. Also, you may notice on the bottom the word Kick. Kick is also another streaming area. We're going to try them out. So, we're coming to you from Kick also today. So, you Kick watchers, hopefully you're enjoying the show. This is your first time catching our show. Be sure to check out our website at uronurse.com, the best place to go for all the information about the show, other podcasts, and our sponsors. And talking about shows, we've got 148 shows for you to pick from. So go to our website, best place to find all of those shows. Also, a lot of you like to listen in the car. You've got a long commute, nothing to do. Go ahead and subscribe to our audio podcast. You can go to Apple Podcasts, Spotify, iHeart, Amazon, YouTube, any of those places to get the audio version. Comes out about a half hour after this show ends, so you'll be able to get that. Hey, just want to reach out to, it's the last day of May, but it is Nurses Month, a time to honor the skill and compassion and dedications nurses bring to every patient every day. So to all you nurses making a big difference, including myself, thank you for all your effort. All right. So today we're joined by Dan Rocker, a licensed clinical social worker and one of the leading voices in the treatment and understanding of paruresis, commonly known as shy bladder syndrome. With years of clinical experience and a deep commitment to helping individuals overcome anxiety-related conditions, Dan has worked extensively with people who struggle with often overlooked but time-limiting effects of paruresis. He's known for his compassionate, evidence-based approach and his efforts to raise awareness about this condition that affects millions, yet is rarely talked about. So with that, Dan, welcome to the show. We also have Lori joining us as one of our experts today. Welcome, everybody, to the show.
Morning.
Good morning, and thank you very much for that lovely introduction, Vic. I thought one of the things I'd start out by telling y'all is that I just recently realized that I have been in professional life for 34 years, but only the last 17 as a social worker. The first 17 years of my career, I was a trader on Wall Street, which is the Venn diagram and overlap between traders and social workers is pretty narrow. But when you want to look at it in even more fine point on it, the number of people who have gone from Wall Street to be paruresis therapists is, well, you're looking at a urinary unicorn. That is me. But in all seriousness, I want to thank you, Vic, for your interest in paruresis, the wonderful videos you put out about the subject in the past, and for inviting me to come speak to you today. I saw on one of your podcasts from a couple of weeks back, and you just mentioned, I'm so grateful to be able to slide in just under the wire for the last day of Nurses Month. So I have an opportunity to wish you both a happy Nurses Month. And in a happy coincidence, May is also Mental Health Awareness Month. And in fact, the International Paruresis Association, of which I am president, has claimed a specific Paruresis Awareness Day, during which we created an hour of free content for our membership. And this year in my video segment, I mentioned that I would be appearing this morning on the UroNurse podcast as one of the ways in which the IPA is always trying to move the ball forward for public awareness of paruresis. So I truly am grateful for this opportunity. Hopefully today I can make paruresis come alive for you in a way that reading about it just wouldn't. I hope I can further stimulate some interest in this curiously neglected disorder, a disorder that Steve Seufer, the co-founder of the International Paruresis Association, and we've been around almost 30 years, refers to as the secret social phobia. In fact, that's the title of his book, the indispensable book on paruresis, The Secret Social Phobia. I further hope to make it easier for you to potentially identify and assess for paruresis in the patients you treat, and having identified it, to provide some resources for you and your patients and a roadmap for possible next steps. So just the briefest introduction to me, as Vic said, licensed clinical social worker here in New York City. I'm in private practice. I have been trained in psychoanalysis and also trained in systemic family therapy and couples therapy, but I'm really best known because 75% of my practice does focus on shorter-term cognitive behavioral approaches to work on the symptom of paruresis. As I mentioned, I'm the president of the IPA, where I have been on the board for over a decade, and I have been involved in some capacity with the IPA for 24 years, since first showing up as a symptomatic trader to one of their workshops in 2001. I've worked with hundreds of men and a much smaller number of women, because I tend to refer women to a paruresis specialist here in New York City, Ruth Lippin. But I've worked with hundreds of men and spoken to perhaps 1,000 people about their paruresis over the years. And on behalf of the IPA, I lead about 60% of our annual workshops. I lead probably a third of the In Real Life weekend workshops, and I lead all of our video workshops as well. So those are my bona fides for presenting on paruresis. And now I'm going to tell you a little bit more about what paruresis is and how it's going to present. So paruresis is the involuntarily, subjectively felt inability to urinate in the presence of other people while under perceived scrutiny. Sometimes visually. Most people think that it's, oh, people are concerned about being seen to be urinating, bodily shy. That actually tends to be not a salient trigger for paruresis. Most commonly, the triggers for paruresis are to the sense that one is being heard, either to be urinating and maybe have a stop-start stream, or worse still, to be heard the accumulating silence that indicates that someone is not urinating, and people, people are concerned of social judgment. Hey, what's with that guy? Why is he standing there and there's no pee sounds coming? And another really salient trigger is time pressure. Think of, when someone steps into a lavatory in an airplane and slides the latch from vacant to occupied. My clients tend to have a sense that a shot clock has started, and that if they don't get out of the bathroom as quickly as possible, there will be a long line of people who are very angry at them. And so they tend to get agitated and a little sympathetically activated and leave the bathroom. So time pressure, a huge trigger. Paruresis is listed by name in Psychiatry's Bible of Mental Disorders, which is known as the DSM-5. It's the Diagnostic and Statistical Manual of Mental Disorders. It appears there on page 203 under the heading of social anxiety disorder. It is a diagnostic feature of social anxiety disorder. And because paruresis only exists within a social context, that's one of the things I'll be returning to repeatedly today. In the absence of another person or a hypothesized other person who could show up, in the absence of another person to be concerned about, the paruresis patient urinates completely normally. Okay. Most of us are familiar with the idea of psychosomatic disorders, that some physical symptoms can be manifestations of psychological problems. The most salient one that comes to mind is selective mutism, where people chatter like a chatterbox at home, but are silent at school. This is the kind of disorder that paruresis is. Urinate fine at home, not so much in other places. In your practice, in your urologic practices, I have to imagine, and this is just an imagining on my part, that the vast majority of physical symptoms that you're treating are related to physical problems that people have. And people with paruresis, this is not the population I'm talking about. I'm talking today about the minority of patients who are going to present in your practice for treatment, who think that they have a physical problem, but it is actually a manifestation of a social phobia. So here is the typical journey of a new patient who shows up in my practice. They might have told their general practitioner that they have a hard time urinating sometimes. So the GP will just make a referral to a urologist. And the urologist may perform a variety of tests with no obvious findings. This is a path that I went down decades ago. And that patient might then leave the urologic office with two prescriptions. One for a medication like Flomax or Uroxetrol, which has not been felt to be effective by most of my patients who tried it. And a second prescription, one for physical therapy, pelvic floor physical therapy, to treat a presumed pelvic floor insufficiency or dysfunction. Now, here's the thing. The patient may or may not, depending on how ashamed they are, they may have been telling both the GP and the urologist all along, maybe in a real quiet voice, that this symptom only arises some of the time. Maybe just in the restrooms at work when there's someone senior to them nearby, maybe just on airplane lavatories, maybe just in other people's apartments if there's not a fan in the powder room and it seems to be too close to where people are sitting at the kitchen table. The patient, if you listen carefully, is reporting symptoms that solely occur within a social context. And so here is the fortune cookie tagline that I would like to get out there today for everyone in the urologic field. If you hear situational, wonder, psychological, I'm just going to say it again. Hey, if you're hearing that a problem is situational, you might want to think that it might be of psychological etiology. And here is the one question rule in that I have developed that is going to help you assess whether what you are hearing about is situational or not. You're going to want to ask your patient, hey, do you ever have this problem at home when you're alone and you are under absolutely no time pressure? Do you ever have this problem when you're home alone and under no time pressure? And if the answer is yes, then chances are you do not have a paruresis case on your hands. If people are having the same urinary hesitancy at home, alone, and under no time pressure as a non-urologist, I do not know what they have, but they do not have paruresis. But if they do answer, no, hey, I urinate totally normally at home, congratulations. You have just successfully assessed that paruresis is probably a factor in your patient's distress. And by the way, I do not use the term distress lightly. Patients only come to see us because this can be quite a distressing and impairing condition to them across every dimension you can think of. Their professional lives. I've spoken to people who've declined promotions that would require travel. Leisure. Don't want to go golfing with their friends because they don't know where they can pee on the course. Relational, don't want to necessarily get involved in relationships if you aren't sure that you can pee at the apartment of someone else. So in its severest presentations, paruresis can come to resemble agoraphobia. And this is, of course, the juncture, once you assess this, at which you might consider splitting the treatment with a psychotherapist, with someone with a demonstrated capacity and a history of treating paruresis. To your patient who has answered no, they have no difficulty at all initiating a stream of urine at home alone and under no time pressure, you might respond to them thus. Oh yeah, hey, that's actually pretty common. I hear about all that all the time. Plenty of people told me they have that problem. Have you ever heard of paruresis or shy bladder? Now, everyone who's watching this, I presume, is in a helping profession, the allied health trades, and in a helping profession. And if you do nothing else, just by informing people that you have seen this before and you've heard what it's called, you're already intervening through the venue of the wonky social work word we use for psychoeducation, which is basically just explaining something to someone. And you've also used the intervention of normalization. You have told someone who might be very ashamed and think that they're alone with their problem, oh no, you're not alone in this problem at all. And as the old saw goes, if you can name it, you can tame it. And there are resources that are available for your patient outside of your office. The easiest intervention, as I just mentioned, is simply to give the condition a name. If your patient is curious, and I suspect they will be, the next easiest intervention is just to give them the web address paruresis.org, which is the homepage of the International Paruresis Association. For patients, once they get to this website, who are interested in just trying to do all the work themselves, they can find links to some free books and videos on the topic. For those who want to meet other men and women who have paruresis, we have links to monthly support groups where they can get on Zoom and talk to normally 20 or 30 people at a time about what it's been like for them in the last month to live with paruresis. And if they want to really grab the bull by the horns and start working on the problem directly, there are also links to our one-day video virtual workshops that I lead, and also to workshops around the country and around the world that are weekend workshops. I lead several of them, and they can actually have an opportunity to meet other people with paruresis in real life, have 16 hours of programming, of psychoeducation, and lots of rounds of graduated exposure treatment. And I'll get to what that is a little later in my talk. And if, oh, by the way, also, if people want to keep it quite private and bespoke, and they want to work with an individual therapist on their paruresis, we have at the IPA's website a list of IPA endorsed therapists. It's called the Shy Bladder Center, and I am the co-director of that center. And pardon me, I just have to take a sip of water here. So you might wonder, do most of these patients, these paruresis patients, do they benefit from psychotherapy? Yeah, most of them do. When you think about it, most of the men who show up in my practice, and it is, as I said, about 90% of my practice is males who show up for paruresis treatment. They don't know much about anatomy. Heck, I don't know much about anatomy. So on some level, these men think they have a problem that involves their genitals. Because as far as they can tell, that's where the urine issue is from or doesn't come from. And the genitals, I don't have to tell a urologic crowd, have multiple functions, including sexual pleasure, reproduction, as well as urination. And as I am certain that you have seen with your post-prostatectomy patients or your erectile dysfunction patients or your PE patients, if a man has a problem with the functions of his genitals, he's going to think about it a lot. And the vast preponderance of these thoughts are going to be negative, shaming, unhelpful, ruminative thoughts. Examples of the thoughts that I've heard articulated in my office, and these are the mild ones. I'm weak. I'm defective. I'm not a real man. I'm a wimp. Does this mean something about my sexuality? I don't think so. And here I want to introduce a new nuance here, a slightly new concept. Regarding paruresis, the factual definition that I gave you a few minutes back about difficulty in initiating a stream of urine in public under certain conditions, we call that the symptom itself primary paruresis. And all these negative thoughts and feelings that I just described, we call that secondary paruresis, as it occurs secondarily to the presentation of having the condition. So Vic, I was wondering if you would now please play the primary secondary video, which I hope illustrates the difference quite vividly between primary.
Why don't we just like take a big old piss on our app? I'm going to open up the app on my phone and we can stream some piss on our little streaming platform. How's that sound?
19, 20, 21, 22.
Yeah. So, I can't piss near other men due to we don't know what reason, but please, go ahead.
Don't mind if I do.
Man, enjoy.
Oh, cool. 2 spots opened up.
You go ahead. I can wait. I might wait for a stall.
Oh, come on, Peter. We're missing the game.
Hi.
Hey.
Damn it. You already started. If I don't start peeing soon, it's gonna be weird. He'll be all done and I'll still be here. Come on, Peter. Pee. Your dad fought in World War II and you can't even pee in a urinal. What the hell's wrong with you?
All set?
Yep.
I know you didn't go.
I'm gonna go pee in a stairwell.
In case it wasn't abundantly clear, in both of those clips, we portray an individual, we see an individual who has primary paruresis. But in the first clip, the guy just announces his debility. Hey, I can't pee next to other men due to what we don't know what reason. Obviously not very ashamed because he's the one who brought him into the bathroom in the first place. But in the second clip, you hear the internal punishing monologue of Peter Griffin from Family Guy. Come on, Peter, your dad fought in World War II and you can't even pee in a urinal? What the hell is wrong with you? That is the internal monologue of all of my paruresis patients and your paruresis patients as well. And so now let's discuss briefly the psychotherapy, because we're going to address both sides, both the primary and the secondary paruresis, as a part of every treatment. As for the psychotherapy itself, it varies a little bit, as all therapies do, from individual to individual. We're supposed to create a new therapy for each individual, according to Carl Jung. But it's always going to consist of these two parts. The first part, the hallmark of behavioral treatment for most phobias, including paruresis, is what's known as graduated exposure treatment, or sometimes called exposure and response prevention treatment, which is exactly what it sounds like. You gradually, or I gradually, move my patients closer and closer to a phobic stimulus until there is a habituation to the phobic stimulus, where they actually learn through repetition that bathrooms are in fact uncomfortable, but not dangerous to them. The client, with some help from me, lists a hierarchy or a ladder of urinating conditions that begins with a very low threshold, with what we call a baseline, where they're 95% sure they could urinate in that situation at that moment. Sometimes it'll be a client in my single occupancy, all gender, and I'm out in the driveway of my building. We start wherever the client is. And then gradually, over time, we titrate up from level 1 to level 2 to level 3. And what this involves is a conscious increase in difficulty and in anxiety, because what we want to do is we want to elicit anxiety. Any treatment that doesn't bring up the anxiety so that you can feel it is effectively a placebo treatment. As one of my mentors, Marty Seif, says, a day without anxiety is like a day without sunshine. So they begin with a baseline, they work their way up the ladder, culminating with an intensely stressful situation, something they would have thought at the outset of the treatment was way above their urinary pay grade. And we just operationalize this, by me having them drink 1.5 liters of water in the hour before sessions, and then go from maybe my office to a library's public restroom, maybe then to a mall, maybe then to a really busy restroom like at Penn Station or the Port Authority here in New York. All the while, the client is actually controlling. They've created the hierarchy with me, but I never make them do anything that they don't want to do. Okay, so it is a co-created hierarchy, and they decide what they want to do at every individual session. So here I want to show a brief clip explaining the rationale and methodology of exposure work. So Vic, if you could just bring up the clip of Jordan Peterson, please.
I mean, the clinical literature seems to indicate that it's true, because one of the things you do, if you're a competent clinician, is you look at what people are attempting to accomplish, and maybe that needs some retooling, but let's assume that they have a goal in mind that would work, right? You've talked it through with them strategically. They have a well laid out vision. Okay, now they're laying out the vision, and they encounter impediments that stop them. And maybe they're impediments that make them afraid and paralyze them. And so then what you do is you decompose the impediment, just as we talked about earlier, until you find a way they can advance that constitutes a genuine advance that they'll actually do. So what you do is you take the problem and you narrow it until they'll face it. Okay, then they face it. Then what happens? They get more competent. That's what happens. And then they get better at facing all problems. So they don't just learn how to deal with that specific problem. They learn a lesson that generalizes across problems. They get braver. When you use exposure therapy, people don't get less afraid. They get braver. And that's way better, because braver moves from situation to situation. Okay.
All right. One of the reasons I included that is when he talks about narrowing the problem, I wanted to give a graphic representation. When we are narrowing the problem from just, I can't pee anywhere, the steps of the ladder, the steps of the hierarchy are how we narrow the problem. Okay. All the while that I'm doing this therapy with my clients, I'm encouraging them to use every opportunity to practice eliminating the paruretic avoidance behaviors that they have historically used to help them cope in the past. I encourage them, instead of trying to find remote restrooms, to try to urinate in more centrally located public restrooms, and to find, instead of the time of day that where everyone else is focusing on something else, to, go during lunch hour, go when you're likely to find it busy. I also encourage them to really build their urinary urgency before going to the bathroom, to stop prophylactically draining off. Pelvic floor physical therapists taught me this term. I don't know if it's common in the urologic field, but they talk about just in case urinating. I've heard them referred to as JICs, just in case. I encourage my clients to eliminate just in case urinating at every private opportunity they have. I also encourage them to set a timer on their phone when they go to the bathroom, to make sure that they actually have a real sense of how much time they're spending in the bathroom, rather than what I call paruretic time. I like to joke that a paruretic 2 minutes is actually 18 seconds, because they're feeling so sympathetically activated that time is absolutely racing for them when they are endeavoring to use a restroom. I was recently working with a young man who I was timing him, and he tried in one position at a toilet, then tried while facing another direction of the toilet, came back and said, I couldn't do it. And I asked him, I said, are you aware of how long you were there? And he said 3 minutes. And I said, because my watch says 20 seconds. There is a real distortion in the time field when people are feeling that they are under stress and that they've got to get out of the bathroom. And so I give them instructions to stay longer than it feels comfortable for them. I'll say, hey, set the alarm on your phone for 2 minutes and stand there for 2 minutes. You don't even have to unzip your fly. Just get used to holding your ground and standing at a urinal for a couple of minutes. I don't do this in a place that only has one urinal, but if there's, if it's a road stop, they can stand at one of the 10 urinals for a couple of minutes. It doesn't harm anybody. And I want them to prove to themselves, yes, they can tolerate the anxiety and discomfort of standing at a public urinal, and also to notice that no one really cares what they do or how long it takes them in a public restroom. Sometimes when I'm working with my clients, I'll model what they view as extreme men's room behavior just to prove that point. I have been known at my workshops to set the alarm on my phone for 20 minutes and to stand at a urinal, grunting with my head, leaning my head against the wall, with my hands down, balled up in fists, or my hands up against the wall, simulating very severe BPH symptoms. And I tell my clients, clock my experience, see what kind of grief I get about this. And what they are uniformly astonished to learn is, you can stand at a urinal for 20 minutes in the food court of a mall in the men's room, and no one's going to say anything to you. They realize experientially that the bandwidth of acceptable behavior in a public restroom is very wide, and is certainly wide enough to encompass their innocuous and silent hesitations. So that's the behavioral piece. That's when we're working on the primary paruresis. As Jordan Peterson just told us, it's the sine qua non of anxiety treatment. I've had clients who've literally wanted to do nothing else but have a non-judgmental wingman accompany them into restrooms as they habituate to them. And the second part of the treatment, when we're addressing the secondary paruresis, the negative thoughts, feelings, self-evaluation, and shame that accrue, this to me is the gratifying part. It's the bespoke and challenging part. It's too multifaceted to explore comprehensively. But this part can be thought of as the cognitive restructuring piece. Through conversation with my clients, we unearth all these negative thoughts, feelings, self-evaluation, and through like a kind of Socratic dialogue, we challenge those ideas to see, well, which of these ideas are actually true, and which other parts might just be distortions in the way that you are thinking or the opinions that you have about these events. This is the time in treatment where I help my clients accept that we are in fact humans, and that humans all do have and are allowed to have imperfections. And then we just work to right size and contextualize the problem. And this is the part of the treatment in which empathy, humor, warmth, and connection are key, all the baseline psychotherapy skills. Frequently, I reframe paruresis for my clients as part of a set of character traits that are actually valued in other areas of their lives. Character traits such as prudence, conscientiousness, vigilance, and in fact, perfectionism, which is a mixed bag in and of itself. But I characterize these traits as all stars in the same constellation. So hopefully by the end of a short-term treatment with me, and most of my clients see me for fewer than a dozen sessions, my clients will first and foremost have a heightened sense of self-compassion. For starters, they learn that they're not alone. And I will commonly ask my clients, hey, what would it be like if you found out that your best friend had a phobia? And then I might ask them, well, would it change your opinion of your friend or the nature of your friendship? And of course, people are saying, no, they don't care if they learned that their friend was afraid of heights. And I say, okay, would it really damage your opinion? Okay, it won't damage your opinion of them. Can you perhaps learn to treat yourself at least as kindly as you would treat one of your friends? The symptom is, again, hopefully right-sized in their lives to the extent that when it recurs, because people have relapses once in a while, it's reframed like a common cold. By no means ideal, unpleasant, uncomfortable, but colds are certainly survivable. And they are not something that necessitates a dramatic alteration in one's life or one's opinion of oneself because they've had a cold. And importantly, graduated exposure to men's rooms without negative consequences reduces the anticipatory anxiety that people are going to have, my clients are going to have in the future going into men's rooms. And this anticipatory anxiety tends to prime the situation in the first place. If you're already nervous walking in there, it's going to make it a little more difficult for you. If you practice your graduated exposure every day, it's just routine when you go into a men's room. So in short, at the end of treatment with me or with any other IPA endorsed therapist, my clients, we generally don't urinate perfectly, but they do so competently in more and more social situations than they were able to when they started treatment. They have markedly fewer anxious moments on a day-to-day basis. They no longer catastrophize or magnify what is essentially a foible. Paruresis in its reduced form, and I keep calling it right size. Let's get it down to the right size of the impact it really has on your life. In this reduced form, it becomes simply something that you know and accept about yourself rather than something that you fear and despise and loathe about yourself. So before I mentioned the one question rule in for paruresis about whether it affects people at home under no time pressure. And now I'm going to leave you with the 3 nuggets of paruresis recovery. Thank you very much, Vic. If patients follow these simple rules, they will make progress. And here they are. Go to the bathroom when you have to go. And this is the get rid of the jigs thing. Don't go when you don't have to go. Practice your graduated exposure all the time. I'm very proud to tell my clients, even during the COVID lockdowns here in New York City, there were fewer than 5 days that I did not get out to make sure I urinated in the public restroom, just to stay sharp. And the third nugget is, if your paruresis is going to impact other people, tell them about it. There is absolutely no reason for this to be a secret. I'm not saying you should wear a t-shirt that says, hey, I've got paruresis. But if you've got a business partner that you're traveling with, or if you're involved in a relationship with someone, tell them about it. To quote Reed Wilson, who is a very well-known anxiety therapist, a kind of legend in my field, and he's a trainer and author as well. If you follow these steps, exposure steps, not my specific steps. But if you follow these steps, you will get better. I can't promise you'll be best, he says, but you can't help but to be better than if you are actively engaging in avoidance behaviors all the time. So in closing, I would like Vic to screen another brief clip which shows a real sufferer discussing his case of primary paruresis and how his exposure and disclosure to other people helped him not fall into the trap of isolation and shame that so many of my patients have fallen prey to. So seldom is paruresis going to appear this directly and this charismatically in your office, but this is a straightforward view of what it looks like. Vic, if you'd play the...
You have to be able to sort of like unburden yourself. And part of that is simply talking about it. Mm-hmm. Like I had one, and this is not really a demon, but to give people a sense who are watching this of like how comfortable I am being forward about things that I struggle with. So oddly enough, one of the reasons that I was also drawn to the military, believe it or not, was I struggle mightily to urinate in front of other people, just publicly going to the bathroom in front of other people. It's not like it's destroying my life, but it's uncomfortable. Like it's easier for me if I'm alone, right? I knew this about myself at a young age, don't have a reason for it. But like I knew when I was like in high school or like in college, like I would go to a bathroom that was private because that was easier for me. And as I got older, I was like, that's not really that normal that this is happening to me. And so part of the reason I was interested in the Navy is they drug test you and they do it really publicly. And it was like, in order to deal with this, I have to go into an organization that literally will force me to have to urinate in front of other people. But like for me, it's sort of like facing these things that are hyper personal, like inability to pee in front of other people, which, you know, I've overcome, but you have to be willing to sort of identify those things. And in my case, I talked to my wife about it before I joined the Navy, and she's like, okay. I talked to my therapist about it recently as well. But it's sort of like, that's a really specific personal thing that if I brought that up in a casual conversation, I'm sure there are people that could actually relate to it. But most people would be like, this is a little uncomfortable that you brought that up. But like everybody's got stuff that falls into that category. Maybe not specifically, but everybody's got weird insecurities and they've got things that drive their decisions that would be to them deeply embarrassing to bring up. That is the reason you have to bring them up, because they will dog you and they will always be there until you deal with them. And for me, it's been helpful and cathartic to state them out loud and then do something about them.
The other thing I've noticed is that when I don't state them, especially in the context of a relationship, is you live misunderstood.
Yeah, that's true.
So like, I like to play out the scenario that you struggle to urinate in front of other people. Your wife might always start to wonder why you don't want to go to certain places, or when you're in those places, you're acting strange. She'll misunderstand that as maybe he's X, Y, and Z. Sure. And then you're dealing with a problem. You're dealing with totally another set of problems. He's like, he's cheating on me. No. It's like, actually, it was just, we didn't have an environment, a safe space where we could talk about the actual issue.
Very
so
true.
I've created like 5 other issues. Yeah. And I have that in my life where I'm like, fuck, if I just told the truth. So it's a shame that sometimes I have to get to the like bust up moment, turn around and say, you've got this totally wrong. And the reason why you've got this totally wrong is because I didn't tell you the truth.
Yeah.
And it's led you off down a path which is really unfortunate. It's caused us more hurt than me just being honest with you.
Yeah.
But look, I'm not saying it's going to be easy.
All right. I include this clip for a few reasons. First off, that's a good looking and admirable guy, an ex-Navy SEAL who is owning up to having paruresis. This is very appealing to my young male patients to have someone to identify with. And as a side note, many of my young patients have endeavored to enter the military and have been turned back because of their inability to urinate in this very public way that has been described. Hopefully that's something my organization will be working on in the future, but we've also been working on it for the last 20 years. So continue to watch this space. But also the interviewer in that clip really sensitively and perceptively drilled down to the heart of the matter. He said, you risk living misunderstood. It's absolutely true. That is one of the most common features, one of the most common sources of psychological distress and pain in the clients who come to see me, because they live lives deeply misunderstood, because they have made a poorly considered choice in their shame, in their isolation. They have decided that it is more important for them to keep their shameful secret than it is for them to actually relate authentically and have a real life. They protect this secret at the expense of doing all kinds of wonderful things. As John Marshall, a former psychiatrist who treated social phobia, used to say about social phobia, of which this is a diagnostic feature, it's not one of the more dramatic mental disorders like schizophrenia or bipolar illness. It is a disorder that is characterized by missed opportunities. And so my patients, your patients with paruresis, they need to gather some perspective on this problem. Perspective that is readily available through a brief course of psychotherapy, or even through just talking to other people who have paruresis, which, as I mentioned, is one of the resources that the IPA offers. So Vic, now you could throw up the, not throw up, but you could put up rather, the PDF of the 5.5 things every urologist should know. Could you make it a little, actually I have a copy here. I just want to make sure that I hit all the issues. Since it's called 5.5 things, I've identified what it is. That's number one. Number two, it says it presents with a slow and weak stream on under testing. You're probably going to get a lot of requests to, hey, can I bring the sample in from home? They're probably, and in fact, there's a little bit of a selection bias at work here. People who really have paruresis and know what going to a urologist office is going to be like for them, they just might not go to a urologist's office because they know they will be confronting their phobia head on. Number three, I don't think I have to tell people, but don't minimize the condition or just tell people you just have to relax, or everybody pees. What's the matter with you? Why can't you pee? I've heard from a ton of clients that they have had very unsympathetic hearings, unfortunately, in urology offices. In fact, my first venturing in when I was 23 years old, I was told by a urologist that I was crazy. What is helpful, bathroom doors. If you've got a bathroom that your clients or patients are going to be using in your suite, those great locks that show that the bathroom has gone from vacant to occupied, my clients love those because they know no one's going to be shaking at the door handle, which is going to cause them to have a sympathetic nervous response. Their startle response will kick in. You could share some statistics that are readily available. 7% of the population suffers from social anxiety disorder. I've seen recent numbers, it might be as close as 13%. The number of people who suffer with paruresis, I'm not sure if it's as high as 7%, which is the number that we've been using in my organization, but it's certainly a non-zero single digit percentage. I'd say maybe 3 or 4% have it to the extent that they're going to need some kind of treatment and help with it. Where to find resources, the IPA. And as the last half year, you guys are half the picture. Most people don't have a tremendous degree of psychological insight. I didn't when I first realized I had this problem. I didn't go see a therapist. I went to see a urologist. So you are probably going to be the first port of call for the individual who recognizes they have paruresis. And so, Vic, I'd like to hand it back to you and handle any questions that you might have.
Yeah, it's great. I'm also going to open it up to the audience. If you have any questions, put them in the comments. We'll be glad to read those off during this show. I'm going to open it up to Lori. We're lucky enough to have our expert on joining us to kind of kick off any questions she might have. Go ahead, Lori.
Yeah, so that was great. I really enjoyed that because you know what? I've been in urology for about 26 years now. And I don't think we focus on that aspect. I mean, we have patients come into the office and they're in the bathroom forever.
Yeah.
They come out and they're like, well, I can't go. I have a shy bladder. And what do? We don't really address that. We just say, okay, we'll try later or what have you. The other case scenario that comes to mind, and I wanted to ask, are there temporary forms of this condition? Because we do have patients that have, we do voiding trials on that have catheters that went into retention. We put and then what we do is these voiding trials where we fill them up with water. We take the catheter out to see if they can pee. Well, here they are in an exam room. They may have a member, a family member, somebody else in the room with them. And now we're saying, okay, let's see if you can pee. And I think sometimes mentally, they probably are nervous because they don't want the catheter put back in. So now they're getting themselves so anxious that, can I pee? Can I pee? And so sometimes in that situation, depending on what their situation is, whether we believe that it might be a physical thing that they're not going to be able, or mental, we'll be like, okay, you know what, just relax, go home. I know you have we put water in your bladder. We know you're going to, why don't you just go home and relax and put them in a more natural environment than in our office where they're nervous and they're, they definitely don't want the catheter put in. So they're trying so hard that it's making them a little bit, concerned and worried.
So yes, what you're describing is what they used to call, I don't know if if DEI has eradicated this term, but it used to be known as the Chinese finger trap. And it's, the harder you try to pull your fingers out, the tighter it gets. There is the thing that's interesting about many anxiety disorders, including paruresis, is the harder you try, the worse results you get. It's like if I were to say, pay attention every step you take walking down the sidewalk. If I weren't to give you that instruction, you just walk down the sidewalk. But, people tend to over focus. The way it's been explained to me, and again, I'm not at all an expert in anatomy, is that there are muscles that are involved in urination that are not under our conscious control. The detrusor in particular, I suppose, and the internal sphincter, urinary sphincter, are less under our conscious control than our external. So you're probably experiencing someone who's doing the equivalent of a reverse Kegel, trying to spread as wide as they possibly can. But the analogy I make is, imagine you have a faucet on the outside of your house. You can open it and shut it, water comes in, water comes out. But what if you haven't paid your water bill and the city shuts off water? Then that's what we're dealing with my clients, that they're trying as hard as they can. It is not that they are not trying to urinate. It's just that for some reason, the detrusor and the internal sphincter are not cooperating with the external sphincter. And so it's funny. Frequently, I have gotten new clients who, the way they realize that their paruresis has become a difficulty is they have a surgical procedure. They must urinate before leaving the hospital. They can't, and they're discharged with a Foley catheter. And then that is its own trauma as they're wandering around for whatever interval with an uncomfortable catheter in them. And that can reinforce that they have a problem, increase the escalation. It's at that point, it's a negative spiral where everything about urination becomes something that is fraught and conflict and a conflict to them.
So I hadn't realized the other thing that you'd mentioned was this mental timing thing going on in people's heads, that I can't go, and I've been sitting in this bathroom so long. I know it's been too long. I think that Family Guy episode really showed that particular thing, that sometimes it's just that anxiety of worrying that people are going to think, oh, you're taking too long in the bathroom. And I didn't realize that was a part of paruresis.
Absolutely. When you think about the reason it's housed under social phobia is because we're really concerned about the judgment of other people. Now, there are a lot of social phobias that most people aren't familiar with. I imagine you've had no reason to hear of deipnophobia, but there are people who, and I know this is not a perfect medical metaphor because they're two completely different systems, but it's like I compare it to the top of the tube and the bottom of the tube. People have problem urinating, it's paruresis. If you have trouble eating or drinking in front of other people, that's called deipnophobia. And it's because, literally they feel that they can't do it. It is a perceived subjective sense that they cannot do it, that if they put food in their mouth, it'll just chew and come back out. And then when they get home, they eat completely normally. So anything that we can feel judged about can become the seed of a social phobia. There's a fear that is of pointing in public. I don't know if you're familiar with that one. There's hyperhidrosis, people who have a fear. Oh, and selective mutism that I mentioned, which is just totally normal chatterbox at home, but will not, speak up even when directly spoken to at school. So it's timing, there is no such thing. I guess it was Abraham Lincoln who's credited with, saying that the proper length of a man's legs is long enough to reach the floor. I like to say the same thing about urinating, is there is no proper peeing time. The proper peeing time is the amount of time it takes you to leave a restroom having urinated.
So it brings up a question here. Are there any particular myths or misconceptions about paruresis that you find yourself addressing?
Yes, there is and one of the reasons I love that video with the Navy SEAL is there's a pervasive concern amongst my clients that they're not masculine, that they are wimpy, that they're incompetent, that as I said, they've asked about, does this mean something about my sexual orientation? Which it doesn't. I mean, I have every configuration in the gender spectrum and every sexual orientation has been through my doors. The concern, and you can see how it comes up. People have, let's have a peeing contest or pee with your buddies when you're a friend, when you're with your friends when you're younger, or one of the most effective ways that was disconfirmed is I had a woman at one of my workshops about 6 years ago who, as she's listening to all the guys go around the table talk about how this impugns their masculinity, she just said, I have born and raised to adulthood 3 children. I do not know how I could be more feminine. This has absolutely nothing to do with masculinity or femininity. This is something that is embarrassing and uncomfortable. And that is an example of what I call right-sizing it. It doesn't mean, it means what you think it means. And so I very quickly try to get people on the path. I'm a big fan of Stoic philosophy. And one of the most important quotes, which is actually the seed corn of cognitive behavioral therapy, is from Epictetus, who said, "It is not events themselves that disturb people. It is their opinions concerning them." So if in the videos that I showed you, in the first video, the guy's like, I can't pee next to other people. And I have met plenty of people out in the world. When I tell them about what I do, they say, "Oh, I've got that. Yeah, I didn't even know that was a thing. I didn't know I wasn't the only one." "Oh, okay. Yeah, it's just, I can't do that." They don't make a secondary meaning out of it. The real problem is when you start to believe that it means something and implies something about you. What I'll frequently say is, needing reading glasses is not ideal. I didn't ask for it, but it doesn't make me feel less masculine because I need them, but I definitely need them.
This way, a good one for Lori, because I was talking with you earlier about the bathroom situation at the Wrigley Field, where the guys have to all, kind of get up shoulder to shoulder in this big trough. Lori, what's it like for women? Because I think it's probably less paruresis, because I don't know what the women's restroom looks like.
You know what? That's so funny that you said that, because I just went to the Cubs game this past Monday. And you know what? I think there for women, and I've experienced this before, is that you've got that long line and people are just, as soon as you're seeing a door open, you got to rush in there and you're like, "Oh my gosh, there's so many people waiting. Let's go, let's go, let's go, let's go." And I think it's more that than anything. At least it is for me. I mean, I don't really have the condition. I only have it 2 ways, and that's one of them. And
but you're aware of that clock going off.
Yeah. Or if it's in my bathroom and my cat's staring at me, I might have a because my cat's a leech and he's got to be everywhere I am, and he's just staring at me, and I'm like, okay, I have to go to the bathroom. Go away, But yeah, definitely it's the timing factor.
Yeah, interesting.
And one thing I could add is that regarding the female experience of paruresis, Just this last weekend, one of my cousins sent me the Miss Manners, which was in the Washington Post. A female wrote in and said, I have this problem where I'm urinating in my office and I can't do it with other people around. And I have a colleague who stands outside the door and talks to me. And what do I do about this? Because I can't urinate in that situation. And Miss Manners said, like, basically tell them, hey, I can't hear you. Go back into the office. We'll discuss it then. That might be a situation where the third nugget would apply to me. If I was talking to that client, I'd say, well, it sounds like this is affecting you on a routine basis at the office. Have you considered telling the person, please don't do this? I have a shy bladder. I'm kind of reactive, and it's like a hyper reactive startle reflex. Could you just go back to your desk and we'll talk later? And the other experience that I've heard is women tend, in a way that men tend not to as adults, to say, oh, I've got to go to the powder room. Would you like to come with me? Men do not say, I'm going to take a leak. You want to, come with me? No, seriously. I mean,
we're not social about it.
It's culturally very different. And I have spoken with women who have reflected with sorrow on the desire to be accepted in a group, a social group, but the members of that group keep on suggesting, hey, Thursday's margaritas night, let's go do that. And you make enough excuses to not go. And the real reason, just like this in the last clip, he said, you live life misunderstood. Instead of just saying, hey, Sally, I can't come, or I'll come for a half hour, but then I have to go because I'm working on this condition. You don't tell people because you're ashamed. And then people stop asking you because they assume that you don't want to be with them. And so that's how this can become a truly isolating, socially isolating condition. I have worked with men who have abjured dating their entire lives because they thought it rendered them ineligible to date.
Are there any great books that you can recommend people to look at? Or
Oh yeah, Steve Soifer. I mentioned it earlier. I wish I had a picture. I can send you a link to it later. The third edition of his book, The Secret Social Phobia, is coming out imminently. Steve Soifer et al. There's several other authors on that one. In fact, actually, I think I have a few essays in this edition. That is the indispensable book. It's got Steve Soifer, the founder, co-founder of the IPA, along with Carl Robbins, a Maryland psychotherapist, was the first guy to write about this. And he is the former head of social work department at several different universities. And he brings both the clinical aspect and the research aspect to it. So you will read more about, the first mention of paruresis in a Portuguese text in the 16th century, up to the latest cognitive behavioral approaches and speculative approaches, such as using Botox injections. I mean, he's dedicated his career more or less to a deep dive into paruresis.
All right, great. And Lori, how often do you see patients that come in with this disease saying, hey, I've got paruresis? To me, it's just
never.
Exactly.
I don't think I've ever, and maybe now I'll be more intuitive on what they say when they say I have a shy bladder and why they're there. Maybe it correlates to why they're there. So it's very interesting. I don't think I've ever heard anybody with that. When you first put that on the screen, Vic, I said, what is paruresis? I mean, I've been in this a long time. I never really knew the name for it, so it's fascinating. I'm really interested.
And I wonder if it's a cultural thing, because what's one of the things Vic and I were talking about before we started rolling today is I just ran a workshop in Toronto 3 weekends ago. And the dozen guys around the table, I just asked them, I said, how many of you have seen a urologist about this? Every single hand is up. I then asked, and how many of your urologists actually knew about paruresis? Every hand went up. This is not my experience with my clients here in the United States. They go to see therapists and are told, there's something wrong with you. Get out of my office. You're crazy. Just drink more water. Like it's some of the the comments, and I'm actually not exaggerating. These are some of the comments that people have come in. So I don't know whether it's covered in medical schools in Canada, but not in the United States. But there is considerable research on it. It's just it tends to sink like a stone when it comes out. I think it's because of the shame, and it's not necessarily the urologist's fault, because if as I mentioned earlier, the client might not really get to the heart of it because they're so embarrassed. They're kind of hoping that magically a urologist will know what to do, or there's a pill, or there's a probe, or a prod that'll fix the situation for them without them having to admit something about it. But that's unfortunately not the case.
Yeah. Well, it's been an excellent discussion on a topic that's really not, as I said, very well known. And here we have two urology nurses that have been, a lot of years between the two of us. And we see a handful that come in. Now, we know there's a lot more out there that are underreported, typically with all these kind of what we call quote unquote closet diseases. There's just more, I think more people talking about it, getting it out will help that situation. Well, we're at the end of our show.
Go ahead. If I could add just one thing very quickly, because I just thought of it, Vic. For any audience members who are fans of the New Yorker magazine, Adam Gopnik is a very prominent author there. And he wrote this book a couple of years ago called The Real Work on the Mystery of Mastery, which incorporates in it a chapter on paruresis and on his graduated exposure work with me to overcome it. It's not a HIPAA violation to discuss it because he put it out in the world. He's very happy. But it is wonderful if you have a client who presents with this to be able to say, is this resonant with your experience? And they will read it and they will feel very seen and very understood.
Great. All right. We got a little promo for next week's show.
Clinical Consultations presents an expert-led, case-based discussion on genital psoriasis featuring Dr. Tina Bhutani and Dr. Rajal Patel. In this dynamic video, you'll gain clinical insights into diagnosing and managing genital psoriasis, one of the most sensitive and often undertreated forms of psoriasis. Designed specifically for healthcare professionals, this episode focuses on real patient cases, evidence-based treatment strategies, and practical pearls for improving patient outcomes. Don't miss this opportunity to enhance your clinical knowledge and confidence in treating patients with genital psoriasis and gain 1 contact hour. Join us next week, June 7th, to learn more.
Yeah, I thought I'd take something a little different that we haven't really talked about in the past. And this is one that patients really suffer a lot with. So we're going to talk about that. Plus you get 1 contact hour for free. So a couple things that came in comments, Fran Foley, who's been a nurse probably as long as I have, maybe not quite as long, Fran. I've never heard of this before. So see, and Charlene Valmer said it's very interesting. And thank you. I've got one more quick video because if those that are interested in doing what I'm doing, which is streaming, I am going to have a talk coming up next week on Wednesday.
Are you a current or aspiring podcaster looking to level up your streaming game, grow your audience, and make your content stand out? Join Vic Sinise, award-winning RN, podcast host, and YouTube creator. He will answer your questions live about podcasting, live streaming, gear, strategy, and building a brand in the health, wellness, or niche education space. Join us June 4th live at 7 p.m. Central Time to ask your questions. Feel free to ask questions in the comment box. The comment box is live on StreamYard, YouTube, Facebook, and LinkedIn.
So there you go. If you want to learn more, check us out. Hey, Dan, it's been great having you on the show. I'm definitely going to have to call you back in because this was a great subject that I'd like to reapproach. And Lori, always great to have you on board to help us out with the show. With that, we'll see everybody next week on UroNurse.